So during this 2017 ASCO session, we indeed heard a lot about the complexity of myeloma treatment nowadays, since we have numerous treatment options, and we can give them either doublets or triplets, and it's quite difficult to figure out which one, which combination we should aim at. I should first say that the scenario is quite different if you're talking about first-line treatment or relapse treatment. In the first-line treatment, it's quite obvious that triplets are superior, and all patients should get triplets if possible. Now you can argue which triplets. In the US, most of physicians are using RVD, revlimid-velcade-dex, while in Europe we're still more conservative and use the VTD combination, velcade-thalidomide-dex, but we may switch in the future to RVD as well. We heard also triplets such as VCD, combining velcade, cyclophosphamide, and dex. However, the triplet is the standard in the upfront treatment. As for the relapse treatment, it is also the triplet, which is a kind of gold standard treatment. However, you may argue that a subset of patients may not really benefit from a triplet. It is fair to say, though, that most of clinical trials, if not all of them, have compared triplet versus doublet, especially revlimid-based triplet, revlimid-based plus ixazomib, plus ilotuzumab, plus carfilzomib, and panobinostat, and all of them showed the superiority of the triplet over the doublet. And it's even more true when you are talking about the monoclonal antibodies such as elotuzumab, and especially with daratumumab, and the two main trials, POLLUX, revlimid-dex plus or minus daratumumab, and CASTOR, velcade-dex plus or minus daratumumab, has clearly shown highly benefits of the triplet, with a gain of about 6 months of PFS. However, we should mention that OS has never been shown to be superior so far, with even the best triplet that has been reported. However, you may claim that some patients, and especially the frail patients, may not benefit from triplets. The International Myeloma Working Group has established a frailty score. That frailty score was established for newly diagnosed non-transplant eligible patients, but you may translate that in the relapse setting, and they have clearly shown that you have 3 sets of patients: the fit, the frail, and the intermediate, and the outcome is completely different. And one of the reasons why the outcome is different is because the discontinuation rate is much higher, twice higher actually, in the frail patients compared to the fit patients. And that is a very important point, especially in the relapse setting, where you want to keep your patient on treatment, and that is the key point in the relapse setting. And therefore, even though we do not have data as such, you may claim that for your patients who are frail in the relapse setting or who have comorbidities, you may start first with a doublet instead of a triplet. I should remind also that there is a trial comparing KD, carfilzomib-dex, versus velcade-dex, and carfilzomib-dex was twice high superior compared to Velcade-dex, with a median PFS of around 18 months, which is not too far away, you know, from the median PFS that you are expecting with revlimid-dex plus ixazomib or revlimid-dex plus elotuzumab. They have a 20 months PFS, and so you may argue that carfilzomib-dex may be a good doublet to start with for these frail patients. You may also think of the combination of pomalidomide plus dex, which has shown some good efficacy, especially for the 17p deletion subset of patients. So for all these reasons, it is usually less toxic, also to some extent less expensive. For the frail patients with comorbidities, you may start with a doublet instead of a triplet.